So topic of the lecture today is lymphatic filariasis. Lymphatic filariasis is a parasitic infection. Like other parasitic infection, they have the same or similar kind of life cycle and similar kind of life manifestations. Now, what's different in lymphatic filariasis is that it might affect not only your organ systems, not only your blood systems, but the basic and primary target for lymphatic filariasis is your lymph system, is your connective system, and it even affects your serous levels. It even affects your serous fluids in the body. So it has rather drastic manifestations, and we're going to talk about what lymphatic filariasis is and what is it caused by and what is the pathophysiology of it. So first of all, let me give you a depiction of lymphatic filariasis, that how a patient might present to you in which lymph system is being involved and with lymphatics are being involved and with lymphatics are being blocked. This is what the patient's leg will look like because of the blockage of lymphatic system, blockage of lymph. This is what you'll look like. Severe edema, which will be even throughout the leg. It won't be just in your legs and not in your feet. It will be even throughout. So let's learn about what lymphatic filariasis is. What is the causative organism of lymphatic filariasis? Now, causative organism of lymphatic filariasis is basically not one but actually three organisms. First of all, we have Wuchereria bancrofti. Next on we have Brugia malayi. And next on we have Brugia timori. Now, these three are causative organisms causing lymphatic filariasis. Now, not all of them have the severe levels of pathogenicity, or not all of them have the same severity. Not all of them cause the same intensity or severity of the disease. But studies have revealed that Wuchereria bancrofti is one of the most severe causing organisms, severely causing lymphatic filariasis in humans, which are mostly immunocompromised in some state. On the other hand, we have Brugia malayi and Brugia timori. They also cause the same pathology, but their severity is not up to the level of bancrofti. So that's what you have to differentiate. Now, what you see here is shapes of these organisms. Whenever you will hear the word lymphatic filariasis, you will come to know that, okay, there are three organisms. We talked about the three organisms, Wuchereria bancrofti, and then we have Brugia malayi, and then Brugia timori. Now, let's talk about the morphology. What do they look like? They are just thread-like. You can see there's this thread-like appearance they have, and their size varies. There are females, there are males. Males are rather small in size. They are between 2.5 centimeter to 4 centimeter. On the other hand, female vary from a size of 8 centimeter to 10 centimeter. Now, the male have a thickness of 0.1 millimeter. On the other hand, female have a thickness of 0.3 millimeter. Now, what we do know, what we do appreciate in this is that females are rather bigger in size than males. So, how do we see that it's a male or female? First of all, you look at the size and you will know that it's male or female. Next, what's the main important diagnostic point? Their tails. In one sex, they're curved, in one sex, they're upped. That's how you differentiate these organisms. That's what morphology is about. So these organisms do not enter the body just by, through your food or through your feet, not like other parasites. No. They are very different in their vector. What's the vector for this disease? Mosquitoes. And not only one mosquitoes, they can be any of them. But in most of the cases, it's Aedes aegypti and Anopheles mosquitoes. And female mosquitoes cause this pathology. Now, where do they come from? So, what we have learned, what we have studied up till now, different studies have been carried out, and what they have proven out is that this pathology, lymphatic filariasis, and these organisms have two life cycles basically. One life cycle they spend in the mosquito, and the second life cycle they spend in the human form. Now, how does that go along? We'll talk about the whole life cycle. We'll understand at which stage they will leave the mosquito and come into the human being, and at what stage they leave the human being and go back to the mosquitoes, and that's how they carry out their life cycle. Now, what pathology does it cause in mosquitoes? Not much. It doesn't have any effect on their life cycle. It doesn't have any effect on the life of a mosquito, but it does have a life on, but does have an effect of life on human beings. Now, before we go on, let me tell you that lymphatic filariasis is the second major cause of disability. Second major cause of disability after leprosy. That might sound alarming to you because it is like that. This pathology varies and it is very severe and it can cause disability in the patient. In some cases, these even go up to the level of amputations. So, what we do know is that their morphology is like thread-like. Females are of more size, more thickness. They are the ones basically causing this pathology. Vectors are mosquitoes in this case. They can be anyone's. And let me tell you that depends upon the regions. In Asia, there are different mosquitoes. In South Asia, there are different mosquitoes. In Africa, they are different. So, it does not depend upon the mosquito. It depends upon the biography. So, if it's from Asia, if this pathology is occurring in Asia, different mosquito will be the cause of it. If it's happening in Africa, different mosquito is going to be the cause of it. So, mosquitoes are the vector that we know, and we know that it's the second major cause of major disability after leprosy. Now, let's talk about the life cycle of lymphatic filariasis. We talked about there are two life cycles of lymphatic filariasis. No, not two life cycles. I'm just saying that for your convenience. It's actually one life cycle, but it has half a part in the mosquito and half a part in the human being. So let's talk about it. First of all, we'll start from this stage, and when mosquitoes takes blood meal from your body, maybe the mosquito bit right here and took blood. Now this blood contains what? This blood contains this larva of these pathogens we just talked about, of those three pathogens we just talked about. Now what's going to happen is that they are going to go to the mosquito. They are going to get into the mosquitoes, and there the life cycle of these pathogens which are causing lymphatic filariasis start in the mosquito. Now what we do know is that if they bite onto lymphatics that they cannot, they'll get the adult worms. Adult worms are found in the lymphatic system of human being. On the other hand, the offsprings are basically found in the bloodstream, in the peripheral blood at night. So, when are the mosquitoes going to bite you? At night when you're sleeping. And what's in your peripheral blood? Offsprings, those larvae are present. That's where it happens. They take those larvae through the blood meal, and then the life cycle continues. Now, at this stage, we're telling you that adults are found in the lymphatics, and offsprings are found where? In the peripheral blood at night. Now, adults produce sheath-head microfilaria that migrate into lymph and blood channels, right? So these adults, male and female, they are present in your lymphatic system, and they're going to produce sheath-head microfilaria. Most of these cases you will see them as MF. You have to understand MF stands for microfilaria. In further lecture, there are multiple instances in which MF is written. You have to understand it's microfilaria. Now that microfilaria is going to migrate into lymph and blood channels. Those blood channels are going to give off the blood to that mosquito, and that's how they will go into the mosquitoes. Next one, what happens? Mosquito takes a blood meal, and these microfilaria are going to go into the mosquito. Now, in the mosquito, microfilaria shed that sheaths, those sheathed. They are going to shed those sheaths, penetrate mosquitoes' midgut, and migrate to thoracic muscle. Now, microfilaria are going to go through the life cycle in the mosquito. First thing they do, that they remove their sheath. First of all, they remove their sheath, get into the midgut, penetrate the midgut, go into the thoracic muscle, and there they start their growth. Next on, they move into the stage of L1 larva. Next on, they move into the stage of L2 larva. Next on, they move into the stage of L3 larva. And all of you who have studied parasitic infections must know that L3 larva is a stage of larva that is mature larva that can cause pathology in your systems. So once it reaches the L3 level, what happens is that it migrates to blood of the mosquito. It migrates to the head and proboscis of mosquito. Once it's in the head and proboscis of mosquito, what happens? Whenever that mosquito will bite, it will somehow ingest that L3 larva in your systems. So that's what happened. That's what's going to happen. It's going to go into the bloodstream of a human being just by a meal that was going to be very simple. So mosquito takes a blood meal. Now this L3 larva goes into the bloodstream. Once it goes into the bloodstream, it will go into the lymphatics. It will go into all other systems. It will reproduce. It will lead to other microfilarias. Those other microfilarias are going to go into the blood again, and the cycle continues. So basically, we have two organisms which complete the life cycle of microfilaria or lymphatic filariasis. What two organisms? Human being and mosquitoes. But which of these organisms carry out its necessary life cycle? And that's mosquito, because that's where they move from microfilarial stage to L3 larva, which is capable of causing pathogenicity. So to keep an image in your mind, you just have to remember three things basically. Those three things are that these pathogens live in your lymphatic systems. Adults live in your lymphatic system. They give off the offsprings which are sheeted, and those offsprings are going to go into the lymph systems, going to go into the blood. That blood will be most of the cases peripheral blood, which will be there at night. At night, mosquitoes are going to come, they're going to suck blood, and without knowing, they're going to suck that microfilaria with that blood. That microfilaria is going to get in, remove its sheath like an agent. It's going to remove its sheath, penetrate the midgut, go to thoracic levels, and start generating there, regenerating there. So what happens? They go through microfilarial stage to L1 stage, L2 stage, L3 stage. Now they're ready to cause pathogenicity. Now they're ready to get back to the human form. For that, they will move to the head. They'll move to the proboscis. There, they will go again into the bloodstream whenever that infected mosquito is going to bite a human being. That's how the life cycle continues. Next on, let's talk about the pathogenesis of lymphatic filariasis. We know how it transmits. We know where does it go. We know what systems is it going to affect. What systems? Blood, lymph, connective tissue, serous levels, all four of them. So all four of those systems are going to get affected. So let's talk about the pathogenesis. The pathogenesis must be very severe, right? Must be very pathognomic. So let's talk about it. Filarial parasites are going to affect what? Epithelial cells and cells of immune systems. What's going to happen in epithelial cells? What's going to happen in cells of immune system? It's correlated. That's what this arrow means. It's correlated, right? So what happens is that in epithelial cells, lymphangiogenesis will happen, lymphatic dilation will happen. Why? Because of the dead parasites, because of the infection of parasite, because of the toxins released by that parasite. So the toxins released by these parasites are going to cause three things in lymph. They are going to inflame it, they are going to dilate it, they are going to get it into lymphangiogenesis, and this will all be because of what? Three things. Again, three things. Number one, because of the toxins released by that parasite. Number two, because of the sensitivity reaction, hypersensitivity reaction that it caused. Number three, because of the dead parasite, because of the presence of a lot of dead parasites. It's going to happen, it's going to get into lymphangiogenesis and lymphatic dilation. Next on, you can see this is lymphedema or hydrocele. What is hydrocele? Hydrocele is actually presence of water around it, accumulation of water around it. That's what hydrocele is. So lymphedema, in which edema is found. You can see the edematous growth here. You can see the edema here. And hydrocele, presence of water. This can lead to elephantiasis. Now, what is elephantiasis? You can see it in the depiction here. Once the lymphatic outflow, once the lymphatic flow is being disturbed in an organism, in an animal, in a human being, what happens is that this leads to toxic effects that will lead to elephantiasis, which we will talk about in some other lecture. But for now, you have to know that these filarial parasites are going to get to your lymphatic systems, going to cause three basic pathologies, which are obstruction, which are inflammation, which are edema, lymphangiogenesis. Now, all of these will be because of dead parasites, will be because of the toxins released by it, and will be because of the hypersensitivity reaction. The way the body reacted to this parasite, the way the body reacted to those toxins which were released by these parasites. Now, these will be the consequences of epithelial cells. What will happen to cells of immune system? That's rather more important, I'll say. That's more important than what happens to immune cells rather than what happens to epithelial cells. So at immune levels, what's going to happen? Inflammatory and immune mediators are going to get affected. Other factors will be released. Deaths of parasites and Wolbachia will happen. Secondary bacterial or fungal infections will come in. And that's also related to or also going to lead to elephantiasis and hydrocele. How did that happen? Because when a parasite is in your body, what's it going to do? It's going to give off the sound of that alarm. Sound of that alarm that I'm here. What's you going to do about it? So our immune mediators and cells of immune systems are going to react immediately. They're going to release what? They're going to release inflammatory mediators. Now, as we did not have more of an inflammation already, so more inflammatory mediators are being released, more immune mediators are being released, which are going to do what? Which are going to cause death of parasite, Wolbachia. Now the death of parasite, we have in this point, we talked about that even that lymphatic dilation, even that lymphatic obstruction is being caused by what? Dead parasite, right? So dead parasites are going to get accumulated, Wolbachia, and next on what? When this is all happening, when immune system is down, it's somehow affecting the epithelial cells, somehow trying to control this level, somehow secondary bacterial infection will come in or fungal infection will come in. Now immunity is already low, so any bacterial or fungal infection that might affect at this time will be causing very much of severe consequences. So these all four factors of inflammatory mediators, immune mediators, deaths of parasites, Wolbachia, secondary infections, all of this will again lead to elephantiasis, lymphedema, hydroceles, all of these will be repeated. So filarial parasite, no matter where it goes, to epithelial levels or cells of immune system, it's going to get into this stage until it's controlled by the drug therapy or the surgical therapy. Next on, let's talk about the histopathology of lymphatic filariasis. Now, lymphatic filariasis have been known to affect different tissues, different levels. But what it affects the most in a male is its spermatic cord, its testes. So what we have here is a cross section or histopathological section taken out in which spermatic cord is being affected by microfilaria. Now these microfilaria affect the spermatic cord, get into the adult form there and cause pathology there. Next on, going into clinical features which are most common. Now, up till now, let's give you a recap. So up till now, we've talked about what those pathogens are which caused this pathology, which were bancrofti, which were malayi, which were timori. All of those pathogens are going to get to your systems through what? Through mosquitoes. Once they get inside your systems, they might go to the mammary cells. Mammary glands are being affected, testes are being affected. They might go there, but what's being affected the most is your lymphatic system, is your connective tissue, is your serous levels, is your blood. These four systems are going to get affected, and once it goes forward, it goes into the mammary cells of a female and the spermatic cord of a male, and it grows there. It affects and it destroys those levels. What happens afterwards is that we have these lymphatic obstructions, we have these lymphedemas, we have all of those pathologies in which dead parasites are there, inflammatory reactions are there, allergic reactions are there, inflammatory mediators are there, immune mediators are there. All of those will combine and lead to what? Will lead to lymphedema, hydrocele, elephantiasis. We talked about that. Now going forward, how will the patient present to us? What's going to be the most common clinical features with which a patient will present to us regarding this pathology? So it varies from what? Varies from asymptomatic always. In the very early stage, the patient will be asymptomatic. Patient won't even know that this pathogen is present inside his body or her body because it's very early stage, and it depends upon the load of that parasite in the body, right? If the load of the parasite is up to a certain mark, then the symptoms will appear. Otherwise, maybe it's your first bite, maybe it's the first L3 larva being injected into your body. There was none other. You have been subjected to this disease for the very first time with the very first larva, so you won't have any symptoms until a certain level, until a certain number of larvae, until a certain number of adult worms, until a certain number of microfilaria are present in your systems, you won't have any symptoms. Once you have reached that parasitic load, once you have achieved that parasitic load, then will come the symptoms. What symptoms might that be? First of all, microfilaremia. What is microfilaremia? We have talked about microfilaria. What is microfilaremia? Presence of microfilaria in your blood is called microfilaremia. So, most common clinical feature will be a presence of microfilaria in your blood specimens. Next on, you have the hydrocele, presence of water around it. We have seen a picture of it, of hydrocele, in which inflammation was there. It was due to lymphatic obstruction and accumulation of water. So hydrocele is going to be the one symptom in male community, obviously. Next on, acute adenolymphangitis. We talked about lymphatic obstruction. We talked about lymphatic dilation. We talked about what is it caused by. So acute adenolymphangitis is one of the most common symptoms. It's acute, it's not chronic, it's just acute. It can be alleviated, it can be relieved. Next on, chronic lymphatic disease. At which stage there is no going back. Now this is, some will call it elephantiasis, but no, it's actually just acute phase of adenolymphangitis. Once it's not treated, it will lead to chronic lymph disease, chronic lymphatic disease. So severity, parasitic load, all of these are very much important factors. And one more factor which is very important is the age of the patient. If the patient is already obese, there's no going back. He's going to go into chronic lymphatic disease because they are usually not going to take care of themselves. It's just an observation. So parasitic load going from minute in asymptomatic case to maximum in chronic lymphatic disease, the symptoms will vary upon the parasitic load, the conditions of the patient, the age of the patient, and other accompanying diseases, other accompanying pathologies. Next one, let's talk about the clinical feature, acute adrenolymphatitis. I guess that was the most alarming one for you, right? So let's talk about it. What happens is that in acute adrenolymphatitis, you are going to have what? High fever. Why? It's acute pathology. Our mediators are going to respond. Our inflammatory mediators are going to respond. Our immune mediators are going to respond. The body is going to raise its temperature in order to combat with this parasite, in order to combat with this microfilaremia. So the temperature of the body will be risen. It will be very high. Next on, you will have lymphangitis. What is lymphangitis? Inflammation. So you will have inflammation of it. Next on, you will have lymphadenitis, which will lead to transient local edema. Now that's the acute and early stage of edema regarding these lymph structures. You'll have transient meaning it will go up, then it will go down, then it will go up, then it will go down. That's what transient is. So transient local edema will come in, and next on, if it's not treated in time, it will lead to local thrombophlebitis. Now these are the clinical features of not this pathology, of actually a symptom of this pathology, a stage of this pathology. Once a certain parasitic load has been achieved and not treated yet, this will lead to acute adrenolymphatitis, which will lead to what? Which will cause what? Which will cause what symptoms? Fever, lymphangitis, lymphadenitis, transient local edema, and next on local thrombophlebitis. Next on, let's talk about the Brugian filariasis. Now it's a different type of filariasis, but it contains more or so the same clinical features. Let's talk about it. The clinical features of Brugian filariasis are going to be what? Brugian filariasis is going to lead to abscess, is going to lead to lymphadenitis and lymphangitis of extremities. Now, what's lymphadenitis and lymphangitis of extremities? Extremities meaning your tips, your hands, your legs, your feet. They are going to get affected. Abscesses are being formed. Now, abscess is a collection of anything. Most of the cases water. Most of the cases just fluid that's been accumulated there. Abscesses will be formed in Brugian filariasis. Now, in bancrofti infection. Now we're talking about 3 different organisms and what pathologies or what clinical feature will be differentiating between them, right? So abscesses and extremity lymphangitis and lymphadenitis are being caused by what? Brugian filariasis. Now, Wuchereria bancrofti infection will cause what? It will cause funiculitis. It will cause epididymitis. It will cause scrotal pain. It will cause tenderness. Now, all of these are related to what? Your testes. Inflammation of funicula is funiculitis. Inflammation of epididymis is epididymitis. And then it will lead to, when epididymitis and funiculitis is happening, it will lead to scrotal pain. And that will lead to tenderness. Now, these are clinical features of Wuchereria bancrofti infection. So once a patient presents to you and tells you that he's only having these problems with the scrotal area, he's only having this tenderness, he's only having this pain in the scrotal area, you will definitely know that it's not Brugian, it's actually bancrofti. So you will get to the treatment of only bancrofti. You will just focus bancrofti. That's what differentiates them. We have the same pathology, 3 organisms. We have to have certain clinical features which will differentiate them in between, that which of these 3 organisms are causing this pathology, is causing these clinical features. Next on, we have dermatolymphangioadenitis, right? In which high fever will come in which chills will come in which myalgias will come in, and in which headache will come in. Now, these symptoms are rather systemic. They're not affecting one organ, they're not affecting one tissue, they are rather systemic. So, what's that going to mean? It means that it's present in the blood, it's affecting your temperatures, it's affecting your muscles, it's causing myalgia, it's causing chills, it's causing headache. All of these are systemic manifestations, systemic symptoms, systemic clinical features, rather than these two, which have, in most of the cases, affecting one system or affecting one site, and bancrofti affecting only one site. Now, on the other hand, this is rather very different. It has systemic manifestations. That's the differentiating point regarding the clinical features. Edematous inflammatory plaques are the identifying points of dermatolymphangioadenitis. I took it out, I separated it from the other symptoms, other clinical features, so that you might get the idea that whenever you'll see chills, high grade fever, myalgias, but it can also be associated with what? Epididymitis. The patient is having epididymitis and chills and high fever. You won't be able to differentiate that rather it's bancrofti infection or rather it's dermatolymphangioadenitis. So what's identifying point in all the clinical features is, for bancrofti, it's going to be scrotal pain, tenderness, in most of the cases hydrocele. In Brugian, it's going to be abscess, and in dermatolymphangioadenitis, it's going to be edematous inflammatory plaques. Next on, let's talk about the disease progression. Once this disease has been caused, once this pathology is in your system, what are the stages or how the disease will progress? You can see a picture of hydrocele here. You can see a picture of elephantiasis here. That are the progressions, that are, you can say, the final destinations of this pathology. And they happen because of what? They happen because of lymphatic obstruction. They happen because of lymphatic dilation. And that happened why? We talked about it. That happened because of the toxins released by that parasite. Number one, toxins released by that parasite. Number two, what? Our immune mediators which reacted to it. They caused hypersensitivity reactions. Number three, inflammatory mediators came in. Number four, dead parasites got accumulated in your lymphatic system and caused lymphatic obstruction and many other causes. And this disease progressed to what? This disease progressed to hydrocele. This disease progressed to elephantiasis. In elephantiasis, in most of the cases, surgical treatment is the only option we have. Next on, let's talk about clinical features in travelers or transmigrants. Now, patients will present to you which have a history of traveling from one area to the other area, or which have a history of traveling to those specific areas, those specific regions which contain this pathogen, or they were exposed to different kind of mosquitoes, or they were sleeping outside and there were a lot of mosquitoes. They'll tell you the history of that we were exposed to mosquitoes there, and the patients or the people present there had this disease. You will get to know that, okay, it's a traveler or transmigrant cariation. So what you'll see in those patients, or the clinical features that you'll look for in those patients, is acute lymphatic inflammation, which will be acute. It's not chronic yet, it's acute because they have just been transmitted with this disease. It's not so late yet. It's not like many thousands of parasites are lying dead in those lymphatic structures. No, it's just been introduced into your body. It's just been introduced to your systems. So it's going to cause acute lymphatic inflammation. Next one, it will cause scrotal inflammation. That's very obvious in male. And whenever the scrotal inflammation will come in, you'll know it's bancrofti, right? Bancrofti is present there. Bancrofti is causing it. Next one, you will have urticaria. Now, why urticaria? Urticaria can be because of what? Because of skin involvement, skin manifestations, dermal manifestations, or it can be because of what? It can be because of the hypersensitivity reactions that occurred because of the immune mediators because the toxins released by those parasites. These two are the basic causes. Next on, you have local angioedema. What is local angioedema? It means that local area, that area which it has been injected in or which is being affected the most, the blood vessels will be inflamed, and that's what's called local angioedema. Next on, you'll have lymphadenitis and epitrochlear, axillary, femoral, or inguinal lymph nodes will be involved. And now, let me tell you in this slide that in most of these cases, we talked about the lymphatic systems are being involved or lymph structures are being involved. Most of the cases, what lymphatic structure are being involved? In most of the cases, inguinal. Inguinal lymphatic structures are being involved the most. They go on, they affect those areas, they progress to the progress in the life cycle, and then they migrate into your bloodstream again. So it will lead to lymphadenitis of epitrochlear, axillary, femoral, and inguinal lymph nodes. So these are the 5 clinical features which will be presented to you from a traveler in which parasitic load has not reached that stage in which you will have elephantiasis. It's just minor levels, but it has caused what? Acute clinical features which involve acute lymphatic inflammation, which involve scrotal inflammation, which involve urticaria, which can be because of any hypersensitivity reaction, which can be local angioedema, and which can be those lymphatic areas which are being involved the most, which are epitrochlear, axillary, femoral, and inguinal lymph nodes. Next on, how do we diagnose this? How do we get to the diagnosis? One thing I've been enforcing on from the very start, the most important thing, the key to a diagnosis is history. You have to go for history. You ask the patient all those important questions that do you sleep outside? Do you sleep without a net? Do you sleep without a roof on your head? Are there mosquitoes in your area? Have you been subjected to those mosquitoes? Are there many ponds present within your vicinity? Are those ponds do those ponds contain still water which is not moving at all? Now, all of these are very important because that's where these mosquitoes grow. So this will confirm that whether they have been infected, whether they have been subjected to those mosquitoes. If a patient sleeps in a net, have not had any contact with mosquito, you will rule out this differential diagnosis, and you will look into other causes of lymphangitis, other causes of it, or other causes of these lymphatic obstructions and these lymphatic dilations. You won't look into this parasitic infection. So this history is very important. Going forward, you'll go for examination, which is general physical examination, in which you will observe the patient, in which you will see the tenderness of the patient, in which you will see the inflammation, in which you will see all of those parameters which are very important in physical examination. And after doing these two things, then you go for what? Now you have, kind of got into 3 or 4 diagnoses, got into 3 or 4 differential diagnoses. Now that's the time to go for what? That's the time to go for diagnostic modalities we have. You don't jump for diagnostic modalities without asking for history. Because if the patient has not been subjected to a mosquito, why are you going to go for those diagnostic modalities? So once you've done history, once you've done examination, next on you'll go for ELISA, which will confirm the presence of this microbe, which will confirm the presence of this microfilaria. Next on, rapid format immunochromatographic card test will be carried out. And what's the most important diagnostic modality we have? That's PCR, which is for DNA. You'll go for PCR, that will confirm your diagnosis. Once your diagnosis is confirmed, you'll go for the imaging. Imaging of what? Your scrotal area, your testes, which will lead to a high frequent ultrasound with Doppler techniques will be used, and you will see this pathology. You'll go for radionuclide scintigraphic imaging, which will show you different areas, which will show you different levels of it, which will show you the severity of the disease in that structure. Next on, you can go for lymphoscintigraphy, in which all the lymphatic systems will be obvious, in which you'll see the obstruction in it, in which you'll see the inflammation in it, in which you'll see what lymphatic structures have been affected the most. After that, imaging techniques, you'll go for laboratory findings again. What laboratory findings you will get? First of all, eosinophilia. We talked about in multiple parasitic infections that whenever the word parasitic infection comes in, here comes the eosinophilia. Eosinophils are the first to rise in a case of parasitic infection. Next one, elevated serum concentration of IgE. We told you that these parasites lead to what? Lead to immune mediators coming out, lead to inflammatory mediators coming out and causing havoc on the own self. Now these IgEs will be higher in concentration and you will have these allergic reactions as well. Next on, you will have anti-filarial antibody, which is being produced by the body. So the presence of anti-filarial antibody is actually a confirmation of this pathogen in the body. Now, going on to the treatment, now that you have confirmed your diagnosis through laboratory through history, through examination, through imaging techniques, through PCR, through lab findings, now you'll go for the treatment of this modality. Now the treatment, before I go on to the treatment varies. The treatment varies with severity. The treatment varies with the severity of the disease. If it's mild, maybe you go for just medical treatment. If it's severe, you go for surgical treatment as well. So you'll go for diethylcarbamazepine or diethylcarbamazine, which is given in 6 mg per kg daily for 12 days. Next on, we have albendazole, which is given in 400 mg twice daily by mouth for 21 days. It means per oral, you give it for 3 weeks. Next one, you have doxycycline, which is given in oral route given by oral route for 4 to 6 weeks. It's a whole course which is carried out for 4 to 6 weeks. Now that's all for filarial pathology. We talked about the causative organisms. We talked about how it manifests. We talked about what's the vector, the mosquitoes and human being. They complete the life cycle of this pathogen. We talked about what's the pathogenicity of it, how it goes on, what's the pathogenesis of it. We talked about the clinical features of it. We talked about how do we diagnose it and how do we treat it. So thank you for watching sqadia.com.